welcome to the deep dive. So today we're focusing on maybe a slightly grim topic, but definitely a necessary one for public health. We're talking about Candida auris, C. auris.
C. auris, yes. It's this fungus that's been causing a lot of concern globally, and the main reason. It's incredibly resistant to our antifungal drugs.
That's the core problem, right?
Yeah.
Multi-drug resistance.
Exactly. It can often sidestep, one, two, sometimes even all three main classes of antifungals we rely on. Plus, it thrives in healthcare settings, spreads easily, and frankly, if someone gets a serious clinical infection, the mortality rates are, they're worryingly high.
Okay, so that sets the stage. But here's the kind of policy wrinkle that makes this timely. Despite C. auris colonization going up and everyone acknowledging the danger, there isn't actually a standardized, federal screening protocol for it in the U.S., is that right?
That's correct. It often falls to, local health departments or individual hospitals to decide how and if they screen.
Which makes local data, like the study we're looking at today, absolutely critical.
It does. We're digging into a study from the University of Kentucky Healthcare, UKHC. It's retrospective, observational, covering roughly July 2021 to June 2024. And it's particularly valuable because it shines a light on a region where we haven't had much C. auris data in the southeastern U.S., Appalachia specifically. It helps fill a real gap.
So our mission for this deep dive is basically to unpack their targeted screening program. We want to see who they identified as high risk and ultimately figure out if this proactive approach actually made a difference in stopping transmission inside the hospital.
And there's a really striking finding we need to get to, kind of the aha moment. It's about where they started finding these C. auris cases after the screening began. It wasn't just that they found more cases, it completely shifted the picture of whether these were hospital-acquired or coming in from the outside. A massive change.
Okay, that's definitely the core finding to explore. Let's start with the setup, the methodology. UKHC, you said it's a big place.
Yeah, large academic medical center. Over 1,000 beds, 1,086, I believe. So before February 2023, their approach to C. auris screening was pretty limited.
How so?
It was mainly reactive. They'd only test patients if they suspected an outbreak was already underway, or maybe if someone had a known exposure, it was more like damage control,
Got it. But then February 2023 hits, and they switch gears. They go proactive. Not testing everyone, but targeting specific high-risk patients. They used axillary and groin swabs, PCR testing. What were those specific criteria they used? Who got screened?
Right. They zeroed in on three main groups, focusing on the highest acuity patients. First, pretty straightforward. Anyone admitted to an ICU, an intensive care unit.
Okay, makes sense.
High-risk environment.
Second, any patient coming into the hospital from an outside facility, think a nursing home, another hospital, long-term care if that patient also had either a wound or a tracheostomy tube.
Right, so markers of complex care needs and potential prior exposure. And the third one, you mentioned it flags particular danger zone. It really does. The third group screened were patients who had an active infection with a carbapenem-resistant organism, a CRO.
CROs. Those are serious multi-drug resistant bacteria, right? Carbapenems are often last resort antibiotics.
Exactly. So the thinking is, if a patient is already carrying bacteria resistant to these powerful drugs, they're in a higher risk category for also carrying other resistant organisms like CROs. It's screening within that multi-drug resistance danger zone.
Okay, so targeting these specific, often very sick groups, what did that yield in terms of just sheer numbers, how many tests, how many positive?
Over the whole study period, they ran over 13,600 C. auris PCR tests. That's a lot of screening. And from those tests, they identified 70 unique positive cases. But here's the key split. Only 13 of those were found before the targeted screening started.
Wow, so the vast majority, 57 cases, came after they implemented the new program in Feb 2023.
Precisely. Post-implementation, their average positivity rate was just under 1%, maybe 0.96%. Fluctuated month to month, of course, sometimes 0, sometimes up to about 2%.
Now, 1% might sound low to some listeners, but in the context of tracking something like C. auris, finding 57 cases proactively seems like a big deal for infection control.
Oh, it's significant. Identifying colonized patients early is crucial, but the truly dramatic finding, as we teased earlier, wasn't just the number, it was the origin of these cases.
Right, the community versus hospital onset shift. Tell us about that, before the program.
Before February 2023, when screening was reactive, only about 7.7%, less than 8% of their positive cases were classified as community onset.
Okay, so mostly thought to be acquired within the hospital.
But after they started the targeted screening, that number just, it exploded. Post-implementation, community-onset cases accounted for 57.37% of their positives.
57%. That's more than a seven-fold increase, basically. Just to clarify, the study defined community onset as a positive sample collected before hospital day 4, right?
Correct, before day 4.
So if you're running the hospital, seeing that jump might initially make you think, oh no, C. auris is suddenly everywhere in the community. But what's the more likely explanation for that massive shift?
It's much more likely telling us that the screening program was doing exactly what it was designed to do. It was finding patients who were already colonized with C. auris when they arrived at the hospital. They weren't necessarily getting sick out in the community, but they were carrying the fungus, probably picked up in other healthcare settings like nursing homes before they even got to UKHC. So it reflects much better detection of this existing carriage. And that's critical because it allows the hospital to put contact precautions in place immediately, day 1, potentially stopping spread before it starts.
That makes perfect sense.
Yeah.
It's detecting the hidden reservoir. Okay, let's pivot now into the risk profile. Section 2, where they tried to tease apart, who was just colonized carrying C. auris quietly versus who developed a full clinical infection. Were there big differences between those two groups?
You'd expect there to be, right? But surprisingly, on the basic demographic level, not really. The average age was similar, around 60 for both colonized and infected patients. And the main reasons they were admitted to the hospital, also pretty similar. Things like infectious diseases, neurological issues, neurosurgery, pulmonary problems common across both groups.
Usually you'd think the outcomes would be drastically different between just carrying something and having an active infection. What did the mortality data show?
Yeah, this is where the study throws a bit of a curveball, and it's a really important insight. For 30-day mortality, the rate was 30% for those with clinical infections.
Okay, high, as expected.
But for the patients who were only colonized, it was 25%.
Wow. 25% mortality within 30 days just for being colonized. That's incredibly high.
It is. And at 90 days, the gap widened a bit, but maybe not as much as you'd think. 40% mortality for the clinical infection group compared to 28.3% for the colonized group.
So those numbers are quite close, especially the 30-day rates. Did the researchers find those differences statistically significant?
No, they didn't. And that's the key takeaway here. It strongly suggests that for this specific population, remember, these are patients sick enough to be in the ICU or have a CRO or come in with complex needs. Simply being colonized with C. auris is already a major indicator of poor prognosis.
So the colonization itself is like a marker of extreme vulnerability.
Exactly. It flags that these patients are already so critically ill or immunocompromised from their underlying conditions that whether the C. auris itself tips over into a bloodstream infection isn't necessarily the main driver of their short-term mortality risk. Their overall health status is just that precarious.
That really reframes how we might think about colonization in these settings. Okay, but the study did try to identify specific factors that might push someone from just being colonized into having that clinical infection. They used statistical analysis for that.
They did. They looked at individual factors first using what's called univariable analysis, just looking at one factor at a time. And they found 5 things that seemed significantly more common in the clinical infection group compared to the colonized group.
What were they?
Diabetes mellitus was a big one present in 90% of the clinical cases, which is striking. Also, osteomyelitis, needing tube feeding, having a tracheostomy or being on mechanical ventilation, and having a urinary diversion procedure.
Okay, that list sounds like a marker of really severe, complex illness and, invasive devices. But then came the analytical twist, right? The multivariable model.
Yes, and this is always crucial for listeners to understand when looking at studies. When they put all these factors into a multivariable logistic regression model, which tries to account for how these factors might overlap or influence each other.
It tries to isolate the independent effect of each factor, controlling for the others.
Precisely. It's a more rigorous way to look for potential drivers. And when they did that, none of those 5 factors remained statistically significant on their own.
So what does that tell us? Does it mean diabetes or having a track isn't a risk factor?
Not exactly. It suggests that while those things are common in sicker patients, they might not be the independent cause pushing colonization to infection. Instead, the model points towards the overall picture. The chronic severity of illness, the complexity, the number of invasive devices, maybe the degree of immunosuppression. It's likely the constellation of factors, that overall frailty and level of critical care required, that's a real underlying risk driver, rather than one specific diagnosis like diabetes in isolation.
That makes a lot of sense, and it ties back to the earlier point about colonization itself being a marker of severe illness in this group.
Ah,
And just quickly, for those who were colonized but not infected, why were they tested? Did that confirm the high acuity profile?
Yes, it did. Among the colonized patients, the single biggest reason for testing was ICU admission that accounted for 50% of them. Another 20% were tested as part of point prevalence surveys, often done of high-risk units. And then having a wound was another reason. It confirms they were screening the right groups.
Okay, which brings us nicely into Section 3, the actual utility. Did this targeted screening program work? Did it help?
The evidence suggests it did provide significant value. Identifying those 57 colonized patients early meant they could implement contact precautions much sooner.
Like breaking the chain of transmission, hopefully. They calculated it found about, 3.5 cases per month?
Around that, yeah, 3.56 cases per month proactively identified.
Yeah.
That's the key benefit, getting ahead of potential spread.
But the study was also upfront about limitations, especially around actually detecting CORs. The test wasn't perfect.
No, and that's an important reality check. They estimated the sensitivity of their screening protocol. The axillary groin swab PCR was around 80%.
80%, meaning it missed about 20%.
Roughly, yes. They found that about 1 in 5 patients who later had a clinical COR specimen, like from blood or urine, within 30 days had actually screened negative earlier. And maybe even more concerning, they had 2 patients who were known to be CORs positive previously, who then screened negative on repeat testing during the study period.
Okay, so a negative screen doesn't definitively rule out CORs. Maybe because colonization can be intermittent or the fungal load is too low sometimes.
That's the likely explanation. Intermittent shedding or low burden.
That 80% sensitivity, though, that poses a real challenge for infection control, doesn't it? If you get a negative result, how much do you trust it, especially in a high-risk patient?
It really underscores that you can't rely solely on screening. It means maintaining stringent standard infection control practices, hand hygiene, environmental cleaning. PPE use is absolutely critical, regardless of a negative test result, particularly in units like the ICU.
And that need for ongoing vigilance is highlighted by another finding, right? They still had outbreaks.
They did. Even with this enhanced targeted screening in place, they reported 2 C. auris outbreaks after the program started. One involved 3 patients, another involved 7.
So screening helps. It identifies many cases early, but it's not a magic bullet. CORS transmission remains a persistent risk.
Exactly. Screening is a vital tool in the toolbox, but it has to be part of a comprehensive infection prevention strategy.
And just briefly, we should touch on the practical side. They mentioned the cost.
Right. They noted each C. auris PCR test costs about $50. Given they performed over 13,000 tests, that adds up. They suggest, reasonably, that a formal cost-benefit analysis might be needed for long-term, widespread use of such a targeted approach.
Okay, so pulling it all together, what's the big picture conclusion from this UKHC study?
I think the main takeaway is that this kind of targeted inpatient screening is feasible and provides really valuable insights. It helped them understand their local C. auris epidemiology much better, especially in identifying that significant burden of community-onset colonization arriving at their doorstep. It showed focusing on high-risk groups like ICU patients and those from outside facilities is a viable strategy for early detection, even if the detection isn't perfect.
And having this kind of specific local data, especially from an underrepresented region, it's crucial as we try to figure out the best ways to tackle C. auris nationally and globally, right? It helps tailor strategies.
Absolutely. Optimizing infection prevention requires exactly this kind of on-the-ground research.
Okay, so let's leave our listeners with a final thought to chew on, something the study touched on that raises broader questions.
Yeah, there was an interesting detail. Of the 10 patients who developed a clinical C. auris infection, meaning it was found in places like blood or urine, 3 of them actually didn't receive any antifungal treatment.
Why not?
Because, according to the study, the clinical team ultimately decided the C. auris finding wasn't clinically significant in those specific cases. Maybe they thought it was contamination or just wasn't driving the patient's illness.
But given everything we've discussed, how C. auris is multi-drug resistant, how even colonization is linked to high mortality in these sick patients, that decision seems complex.
It's incredibly complex. So the provocative thought for you is this. In these very high-risk patients, how confident can clinicians be when they draw that line between colonization, just carrying it, and true significant infection that requires treatment? Especially with a pathogen like C. auris that's so inherently dangerous and hard to treat. Balancing the need to use antifungals wisely, stewardship against the risk of undertreating a potentially lethal infection. Where do you draw that line? It's a tough bedside decision.
A really difficult balancing act between potentially life-saving treatment and responsible antimicrobial use. That's definitely something to think about. Thanks for joining us on the Deep Dive.